Okay, thanks so much for joining us this morning for Ground Rounds. I apologize I'm not there in person. If you are there, please take a moment to meet and give thanks to our sponsors, Novartis and Pfizer. This morning, Dr. Maen Assali, one of our senior fellows, will be presenting on intravenous platelet units. Dr. Assali came to us from one of the Brown affiliate hospitals. He's worked hard. He's got a great fund of knowledge. He has done research with Dr. Berlakis. He recently passed the very challenging echo boards, is sitting for the nuclear boards next week. And after completing his general fellowship, he will be doing interventional fellowship training at the University of Texas in San Antonio. Thanks for presenting at Grand Rounds, Maen.
Yeah, thank you, Dr. Harris, for this introduction, and thanks everyone for coming in this morning for this lecture. So our talk today gonna be about intravenous antiplatelet agents. It's gonna be travel back in time just to see how did this whole topic evolved over the years. Certainly very evolving field. So things we want to discuss. So what is the role for, and I'm going to refer for all glycoprotein 2B3A inhibitors as glycoprotein inhibitors for simplicity's sake. So what's the role for glycoprotein inhibitors? And what's the dosing, proper dosing for this, for appropriate dosing? What's the limitation about the data we have about it? And does it have a role these days in acute coronary syndrome? And briefly at the end, we're going to touch base about cangrelor as it's another IV antiplatelet agent that's worth mentioning. If what's its role, dosing, which clinical trials did actually go through and basically help us use this agent, basically. So at the beginning, I'm going to start by presenting a case with no ending. It's one of the cases I've actually encountered at the beginning of fellowship. Very challenging case. The point of the case not to see what happened with the patient, but just to show that there may be some cases where you need your other agents. You don't have enough to do for the patients, very complex case. Maybe there is agents you need to extend and use that you don't normally use on a regular basis. So this is a quick summary of this case presentation, and then we'll go ahead with the actual presentation for intravenous antiplatelet agents. So this is a 61-year-old, no past medical history, comes in with EMS, symptomatic, short of breath, low blood pressure, got intubated in the ED, and we have the AKG on this slide. We can certainly see all these ST elevations on the inferior leads. And what's striking again, also the fact there is some AV dissociation. So we jump into complete heart block here, got transcutaneously based in the ED, sent to the cath lab. First thing they do in the cath lab, transvenous pacing, making sure that this patient has adequate blood pressure, and then obviously go for the lesion, which, as you guys predicted, it's in the RCA. And this is the angiogram quickly to show. So there is a proximal RCA lesion in this angiogram. So what's been done, complete occlusion, one drug-eluting stent. She already got Brilinta or ticagrelor and aspirin per protocol. And just to mention here, platelets was 224K, and I will let you know why I'm mentioning this part. She was started on, so it was facilitated with bivalirudin, the cath lab or the intervention. So good results with PCI. She was at that point intubated, so you cannot get much symptoms out of the patient. She went out of the cath lab and she was noted to go into complete heart block again. So suspicion that something happened with the stent. Went back to the cath lab, and they find complete occlusion again. So what they did, thrombectomy, couple of more stents, making sure with IVUS that we have a proper sizing for the stent. And at that point, she was placed on eptifibatide drip. And we're gonna touch base about the dosing shortly. The rationale was, okay, there is complex lesion, no reflow. Maybe we should use eptifibatide in this case. So CBC checked later on when she went to the ICU and noted that she had significant drop in her platelets, 36,000, and was confirmed with another testing citrate tube, and it's actually 36,000 basically, or so. Eptifibatide drip was stopped, sent back to the cath lab, got more. Actually, what they saw next time, there is a flow, TEMI 2, but there is a clot extending across the whole vessel. Thrombectomy, they tried their best, but went back to the ICU. So, and no glycoprotein 2A3B. So this is a quick summary of this case. The presentation, again, is not about what happened, although hopefully to some point, okay, trajectory for this case later on, she did okay. But I think what I want to touch base here and mention is that the use of intravenous antiplatelets. When should we use them and when should we not? So I have a couple of slides about basic biology, so a little bit dry material, but it's not going to be long, few slides, just to understand the concept for antiplatelet agents. As we know, ACS is a black rupture. So you have a black rupture, platelet get activated, get stuck to the endothelium or the collagen under the endothelial layer of the vessel. This is mediated by so many receptors, but things just to keep in mind, it's involving glycoprotein on the cell surface of the platelets. We have some von Willebrand factor activity here. So this is a nice kind of scheme, just a picture to show you. Keep in mind, this is glycoprotein 2B3A or glycoprotein receptors. And we can see it helps cross-link all these platelets and also help it like adhesion to the cell, to the endothelium, basically. Involve a lot of signaling. And this is another image, and I will show you the one that's more clear. All these are agents that does act on the platelets, activates it one way or another. Just keep in mind, ADP receptors is where we have our P2Y12 inhibitors, where they work, where we use them. Different other factors play a role, long list. So this is another picture. Again, summarizing what I just said, adhesion, activation, and aggregation, all mediated by multiple factors. And you can see all our agents, they act one way or another. They either, mostly, basically, act antiplatelets agent, they act on the ADP receptor, like the common agent we have today, Plavix, Prolenta, Prasugrel, or they act on the actual glycoprotein 2B3A. So you see it's downstream. So the end result is you'll have the cross-linking between those platelets. This is a very nice image too, and also summarizing all our agents that we use. But we're not gonna dig deep so much. We're gonna just focus on these two receptors, glycoprotein 2B3A. This is some mistyping here. And the other one is the ATP receptor. So these are two, but you can tell that this is the final end product of this activation. So if you block things here, you're gonna be very effective. Okay, and exactly so. So if you block the glycoprotein receptors, you achieve very high inhibition for those platelets, 80 to 90%. Quite a bit, compared to aspirin, like 10%, and the other agents, 30 to 50%. So what are glycoprotein 2B3A inhibitors? We don't see them much used, but they're there. Two of them at least, they're there because apixaban is out of the market since 2019. It's no longer available in the US, which is a monoclonal antibody. We do have the other two agents though, eptifibatide, which is known as integralin, and tirofiban, agrestat. At least in my fellowship, I was more exposed to integralin, eptifibatide, but the other one is also exist. Okay. This is a summary of a few trials that show us what's the dosing. I'm not going to go through this because we're going to discuss what's my point here in this presentation to see how the clinical trials lead us to where we are today. What's the question that's been asked over the last 25 years? The earlier trial was done in 1997 or so. So there is limitations. The main limitations with these trials are two. First, we did not have a good drug-eluting stents back then. We did have bare metal stents. The other limitation is we did not have a commonly used P2Y12 inhibitors or the newer generation of them or the newer medication like prasugrel or Pralenta, cangrelor. So I'm gonna first briefly talk about the pharmacodynamic and pharmacokinetic of these agents. So integralin, it's a non-immunogenic. And the reason I'm saying this is because apixaban was associated with some cases of immune reactions. It's a small molecule, does not cause much side effects. And the major side effects with these agents are bleeding. And we're gonna say whose population are more basically prone to bleeding because you have a 50% clearance of these agents through the kidneys. You can imagine if you have those CKD patients, you're gonna be careful with dosing. So this is effect right away, 10-15 minutes, and you have your effects, antiplatelets effect. You stop the medication, few hours, 2 to 4 hours, you have it reversed. So they're quick on, quick off. So that's why there's an infusion protocol involved. How did we reach with this funny bolus infusion, 10 minutes later, another second bolus? We're gonna show through a clinical trial here. So it started with, so there are 3 trials that tried to find the optimum dosing and actually the effect of eptifibatide. Does it work? Does it not? And what's the appropriate dosing? So this is the first one of them, IMPACT 2. This is the dosing. You will have a bolus of 135 and then an infusion of 0.5. Or the other treatment arm, you'll have slightly higher infusion. And you compare this to baseline being aspirin and heparin. And this is involving all these cases who need elective, urgent, or emergent PCI. What we found, you will have some improvement in primary endpoints with these patients. Most of the primary endpoints studied at that point, periprocedural MI, death at 30 days, and recurrent admission with requiring basically target vessel revascularization. These are the major primary endpoints. It's a composite endpoints that most of these clinical trials studied. So you will see that the higher dose maybe made some difference, but actually on the opposite side. So the higher dose was slightly higher event risk. But again, I don't think there was much significance difference, but the difference was with the placebo group. So you will have some decrease in events. But what we noticed here, that when you compare this with the apixaban results, they were not as robust as we expected them to be. So the theory here, we did not achieve good antiplatelet agents with this dosing. So a couple more trials came on the way. So we have Pursuit. Pursuit trial basically looked at eptifibatide again with a different dosing, 180, 1.3, again, different dosing protocol. We found an effect, but still not great. And then comes to the latest trial that tried the double bolusing and the continuous infusion protocol, which found basically we achieved the desired platelet inhibitions with this new dosing, and we have our effect basically in these cases in terms of decreased composite endpoints. Inconsistent use of P2Y12 inhibitors. So this is the limitation. Overall, I would say yes, pre-P2Y12 inhibitor era and also pre-newer stent generations. But what we got out of these trials, we know that, okay, we need to do a good job in inhibiting the platelets. That's giving us better results, as we see from the composite standpoint, composite endpoints. So then here comes the other one, tirofiban. It's again, very similar characteristics. Short half-life, you stop it in a few hours, you'll have that effect reversed. It does achieve a very good inhibition for ADP-mediated platelet activation, so more than 80%. It's not a double bolus, it's a bolus followed by infusion. And you will achieve your overall platelet inhibition, but almost same characteristic in terms of the clearance. 40% cleared by the kidneys. So you need to be careful with CKD patients. Thrombocytopenia, they're there, but not that much. So thrombocytopenia was observed most with apixaban. It was still reported as 1% in both eptifibatide and tirofiban. So it's something we look for, but was more common with apixaban. So how about the trials in general for you have PCI. And this is, again, the era of bare metal stents. Overall, we achieved 35% risk reduction in a primary endpoints. The majority of this is driven by periprocedural MI. You have decrease in periprocedural MI when you use these agents. There was no study that was dedicated for saphenous venous graft and these agents. But we were able, through pooled analysis, to see there is not much benefit out of using them if you have a SVG graft. So then comes the ISOR-REACT and ISOR-REACT-2. Both of them looked at apixaban, and they want to see, okay, what population of patients should we use these agents on? Should we use it on everyone who's getting a PCI? Is there some group that would benefit more? And this graph, if you take a look here, it was placebo, apixaban group, and you can see patients with positive troponin were more likely to have all that benefit from using apixaban, more so than people with or patients with troponin negative. So what this study point that higher risk patients to begin with, obviously anyone with ACS or a positive troponin in that case, will be at higher risk than someone with negative troponin or probably stable ischemic heart disease. And this is just a graph showing how the benefit was. So more than without using clopidogrel also, this is an interesting point. If you have someone who was pre-treated with clopidogrel, if this happened before 3 hours of the angiogram, you almost approach that point where you may get some improvement in composite outcomes. Okay, so anyone with troponin positive, you're more likely to benefit out of using apixaban in this trial. Basically, those are ISOR-1, ISOR-2 REACT trials, which they looked at the low risk and high risk patients. Given that, the question comes next, should we use them only when we do the angiogram, or should we use them the night before, just like heparin drip, to achieve good platelet inhibition by the time these patients go to angiogram? And that's what the early ACS trial tried to answer. We have a good number of patients. You'll have early group, and you will have delayed or downstream. Once you go to the cath lab, you will have the basically glycoprotein inhibitors. It found that there is no much difference. Statistically speaking, it did approach significance. You'll have the odd ratio of 0.89 when you give those patients the glycoprotein inhibitor the night before, or just upstream 12 hours before the intervention. That's why, just because this showed some tendency towards some improvement, a meta-analysis was done to see, is this true that if we give it upstream, we're gonna have more benefit relative to downstream? It's true, but at the same time, significant more risk. So 23% higher risk of having bleeding with these agents, and modest reduction in overall difference if we give it in the cath lab or prior. So consensus back then, probably not a good idea, because the risk outweigh the benefit here. So modest reduction and significant increase of bleeding, so it's not preferred to do an early glycoprotein inhibitors. How about, can we use them as a bridge? So we know all these PO oral agents, antiplatelet agents, they take time to kick in. They can take 2 to 4 hours until you have their antiplatelet agent effects starting. Actually, I will show you a couple of graphs now to emphasize that point. So then comes that trial, fabulous, faster trial, try to answer that question. And what they studied here, they did not try to answer what's the endpoints, how much different gonna be if you use this agent or not, but it's try to answer what's the platelet inhibition like at 30 minutes after you administer these agents. And these agents meaning are cangrelor, tyrofibin, which is our glycoprotein inhibitor, cangrelor, which is an IV P2Y12 inhibitor, and tyrofibin, and compare this with prasugrel to give it as PO agent and see what's the platelet inhibition like in 30 minutes. So this is how they randomize patients. You'll have almost 40-40 on each arm, 40-40-40. And you basically look at the platelet inhibition. This is a nice graph that summarizes it. So this is the 30-minute point. The orange here is tyrofibin, glycoprotein inhibitor. And you'll have cangrelor here, and you'll have your chewed or integrated prasugrel. And you look at the antiplatelet agents effect. At 30 minutes, you have amazing inhibition with the glycoprotein inhibitor, actually 90, 95. You'll have also that achieved with cangrelor, but much lesser extent. And the least out of them would be our PO agents, prasugrel in this case. But they pick up. In 4 hours, you'll achieve your results. The rest, they will start to wane. So there is this period during the intervention. The question is, should we use those agents as a bridge to achieve antiplatelet or inhibition, basically? So this basically confirmed that tyrofibin was superior in terms of inhibition of platelets. This is not endpoints or improving outcomes. It's just about the concept of it. So this study was basically answer that question. And then comes the other questions, should we use it in STEMI patients? So again, those are a lot of trials I will go through. At the end, I will try to summarize what you need to get out of this, basically, the main usage today. But this is just trying to answer how we reach what we know today about these agents. So studied same thing. Those are 30 days ischemic endpoints. Those are two trials that studied this, BRAVE3 and FINESSE. So FINESSE tried to answer, should we give those patients before they reach the cath lab? There are gonna be delays, could reach 90 minutes until they have door-to-balloon time. Should we try to achieve, in a way, quicker revascularization until they reach the cath lab, have the definitive therapy with a stent? And it utilized 3 treatment arms. One of them is placebo. The other 2 they called facilitated arms, because we used apixaban and have dose thrombolytic, or apixaban alone. What we found, there was no difference in composite endpoints. It did show that those arteries, when you actually start the angiogram procedure, they more likely to be, at least have some flow, whether TEMI 2 or TEMI 1 at the time of angiogram. But it did not differ in terms of the mortality, events, composite outcomes. So was not, then this study basically answered that question. That's probably not a good idea, just upstream. And also BRAVE3 tried to answer similar questions, used a different modality, tried to show if we use apixaban upstream before they go to the cath lab, can we get more, or can we have infarct size reduction? Using technetium study, that actually failed to prove that that's the case. The next question that came, okay, maybe we're not achieving the results we want because we are giving systemic apixaban. Maybe if we give it intracoronary, we will have better results versus intravenous. So that was actually what the IDA-STEMI study went through. And it failed to show a difference between intracoronary and intravenous in terms of the composite endpoints. This is the structure of this study. Again, it randomized patients to intracoronary, intravenous, and did not show statistical significance. This is pooled trials that took a look at intracoronary, intravenous. There, as you can see, it approached significance with intracoronary, but it did cross the 1 when you have pooled analysis through multiple trials that went through this question. There is some trend here, but as you can see, it was not statistically significant enough. So another trial came along and tried to answer this question, but at the same time, in combination with thrombectomy. Would we achieve better results with STEMI patients if we use both thrombectomy and intracoronary apixaban at the same time? Will we have our primary endpoints? Will we have less infarct size by CMR at 30 days? That's the question. And majorly, it looked at intracoronary more than aspiration versus no aspiration, because this is more of a secondary endpoints but the primary endpoint was powered. So this is the structure of the study. So randomization happened to no aspiration or manual aspiration, and then further categorized into intracoronary or no intracoronary apixaban. So there was no intravenous arm here. It's whether the patient will get thrombectomy and whether they're gonna aspiration thrombectomy or whether they're gonna get also apixaban intracoronary in that case. And with what you can see from this, I highlighted intracoronary and no intracoronary, you will have some significant decrease in infarct size if you use intracoronary, but not significant difference with thrombectomy. So it did differ between two prior trials. This results, in a way, contradict slightly different results from prior trials. And those two trials, the one that we just mentioned, IDA-STEMI, which showed that intracoronary did not actually make much of a difference compared to intravenous, and also showed a slightly different finding that the TAPAS trial, which tried to answer the question about aspiration thrombectomy in STEMI patient. So TAPAS trial showed some improvement, unequivocal mortality benefit, although, but this one did not show any benefit. So it was not clear whether this has to do with any stenting, like if any of those patients who had thrombectomy had subsequently stenting, did that affected results in these two trials or not? The other one, IDA-STEMI, we're not sure about the delivery of the glycoprotein inhibitors, delivery through a microcatheter. So some technicalities, we were not sure about why the conflicting results. Given all the prior guidelines at that point said it may be reasonable, class 2B, to administer glycoprotein 2B3A inhibitors, or glycoprotein inhibitors, in the pre-cath lab for STEMI patients. But again, the evidence is contradicting, as you saw in the prior trials. The major drawback that we already very aware of is bleeding. And that was also a subject of subsequent trials. Should we give glycoprotein inhibitors for shorter duration to curb that side effect? And knowing that most of these trials happen in the transfemoral approach era, so most of these cases or clinical trials studied cases with transfemoral access point, not transradial. So there was question, maybe we're having more bleeding, we'll have less bleeding if we use different approach. So I think the brief BCI did good job in answering the shorter duration for these agents. Should we give infusion for 18 hours, or should we just do a 2-hour infusion and that's it? Would there be any difference? It actually showed, okay, you'll have much better measured bleeding. So you'll have 1% versus 4%. And you don't necessarily have so much difference in ischemic endpoints. So again, this is an analysis for a huge patient number, more than 21,000, showed that, okay, you will get lower rates of bleeding. You will not get statistically significant difference in ischemic endpoints. And that's why a brief is an option, brief infusion for these agents for 2 hours, not necessarily for 18 hours after those interventions, if you decide to use them. So the safety endpoints, it's worth mentioning that the bleeding mostly happen as GI, GU, and that's the majority of it. It's rarely intracranial or solid. So there's no reported intracranial solid organ bleeding with these agents. Thrombocytopenia, as we mentioned, happen more with abciximab, still happen with the other two. And bleeding usually happen with CKD patients or when you use excess dosing. So where we are today, and this is a screenshot from the, basically from the guidelines, when to use it. If you have ACS and you have a large thrombus burden, no reflow or slow flow, they may be reasonable to be used as a class 2A. So majorly, we're talking here in the cath lab, you're having difficulties, case that's high thrombotic burden, you'll have difficulty achieving reflow in the vessel. There may be reasonable use, class 2A. But no benefit when you have those stable ischemic heart disease patients. Class 3, harm. So this is the summary of glycoprotein to glycoprotein inhibitors. Given that it's worth mentioning also cangrelor, as it's another agent, an intravenous agent. We use it sometimes. I want to show you a few trials that actually studied this and then summarize the whole presentation. So you will have cangrelor. It's an IV P2Y12 inhibitors. It starts fast, and 2 minutes you'll have your action, and it's reversible within 1 hour. So very quick, quick on, quick off. You don't have to worry about dose adjustment with people with kidney disease. Thienoberidines, antiplatelets like Plavix, Prasugrel, they interact with this agent. So you need to keep that in mind. If you have Prelenta or ticagrelor as non-thienoberidines, they don't interact with cangrelor infusion as a non-competitive inhibitor. So you need to be, I will show you how you switch. Basically, if you have someone on IV cangrelor, and we'll mention the indication in a second, you need to stop the infusion before you actually start giving those patients their Plavix or Prasugrel in that case. But you can, at the time of infusion, you can still give these patients Prelenta, because they come under the same category. And this is where the recommendation basically for these agents, they may be reasonable to use in peri-procedural ischemic events to decrease that in patients undergoing PCI and who are not on P2Y12 inhibitors. To bridge the gap we'd seen a few slides away in terms of those PO agents take 2 to 4 hours to start achieving their blood effect of antiplatelets inhibition. So that's why it got to be class, and the actual trials that actually studied the cangrelor are the Champion series of trials, 3 trials, Champion PCI, Champion Platform, and Champion Phoenix. The first 2 showed some tendency toward benefit of using these agents in P2Y12 naive patients who were not previously on these agents. But the last one and the pooled analysis of all 3 trials showed the benefit of using them in such population. That's why it got the class 2B. So Champion PCI randomized patients did not show much difference whether you randomize to Plavix or cangrelor. Right off the bat, like at the start, before you beginning your PCI, you'll have patients start with Plavix or cangrelor. You did not have much difference. When you go to the Champion platform, primary endpoint was not met and the trial was stopped, but did not show, because there was presumption it's unlikely to show superiority. It did show interesting finding at 48 hours that you'll have less stent thrombosis when you use cangrelor rather than oral agents, P2Y12, and less death at 48 hours, which this effect, if you look here, this is, I know it's slightly small, so it's tough to see, but at 30 days, they did not have much difference at 30 days, but at 48 hours, you show some benefit of decreasing stent thrombosis and death. So comes the last one, which did the same thing, studied on a larger pool of patients, and showed that you will have less events with cangrelor. So all 3 trials made it to the guidelines as 2B. Okay, it may be reasonable. If you have a patient comes in, they're not on these agents, maybe it's worthwhile. You can use them on occasion. The other one use for cangrelor is, okay, what do you do if you have multivessel disease, comes with ACS, and you think they're gonna be going into CABG, but they already received their P2Y12 inhibitor load, and their cabbage gonna be in few days. Should we bridge them? And that's what comes the bridge trial. Try to show that would there be a benefit with those high-risk patients that waiting for their revascularization? Should we put them on a drip and keep them waiting for their surgery? And the design was, you see, as we doing in clinical practice, every day you stop prasugrel or Plavix, Brilinta prior to cabbage, 5 to 7 days prior. Okay, should we start cangrelor here and stop it few hours prior to surgery and then restart the PO agents, or put them on a drip few hours after? Would that make sense? So the bridge trial, it did not look for outcomes, did not study events, it did, or mortality. It tried to focus on the platelet, on two things. First, how much platelet inhibition are we achieving? And are we putting those patients at increased risk of bleeding if we put them on this drip, cangrelor, prior to their cabbage? And that's what it got. So we got amazing platelet inhibition, P2Y12 reactivity unit less than 240, achieved in almost every patient who was on cangrelor. And you did not have excess bleeding with these patients during their cabbage if you stop the cangrelor drip 1 to 6 hours prior to surgery. The limitation, again, just like I mentioned, did not look at events or did they improve outcome or ischemic endpoints. That we did not answer with this trials. To summarize this whole thing, so what should we know after all these trials about these agents? Where should we use them and how long and what should we use? So you have someone who comes in already on dual antiplatelets, probably, or not probably, probably shouldn't be using them. They do achieve immediate antiplatelet effect from all these trials that we took a look. So we look at strong antiplatelet effects comes with the risk factors, basically the bleeding. The bleeding majorly happen in older adults, women, and patients with CKD. That's what's noted from the clinical trial. Optimum duration, how long should we keep them? It's reasonable to keep them for a few hours after. Does not have to be the 18 hours, the whole full 18 hours according to the clinical trials, because the brief PCI showed that not much difference in terms of ischemic endpoints. How about elective PCI? Should we use them? Same thing. If you think that you did not have good angiographic results, there is a high thrombotic risk, may be reasonable to use, class 2A. Thrombocytopenia, it happens more with apixaban, still happen with eptifibatide, 1% in eptifibatide. Just like our case from the beginning, maybe it has something to do with the eptifibatide she received, the significant drop in platelets, but something to watch for. So non-STEMI, does it have a role? Weak evidence, majorly, again, this is summarizing where you use it with those non-STEMI cases. You have it in the cath lab. We mentioned before, no slow reflow, you don't have great angiographic results, large thrombotic burden, evidence of ongoing ischemia by the AKG or the patient symptomatic, ongoing, may be reasonable. And when should we use them? Should we use them early before they come in or at the time of the angiogram? Those questions answered by the acuity and early ACS trial, majorly telling us probably not a good idea to give them early. You're getting more bleed at much more bleeding and much less benefit out of this. So use them at the time of the angiogram. How about the cangrelor? All champion trials, the first two failed to show superiority, but the third one showed. The pooled analysis out of all three did show some lowered rate of primary composite efficacy endpoint. So something to keep in mind, and that's why they have a class 2B. If you have someone coming with not prior on glycoprotein or not on P2Y12 inhibitors may be reasonable to start cangrelor until you achieve your antiplatelet effect in a couple of hours with these PO agents. And sometimes in STEMI patients with cardiogenic shock, you cannot give these PO agents. They're intubated. Difficulty with the PO axis may be reasonable to use cangrelor. And that comes to my end of my slides. Thank you, everyone, for listening. Any questions or input as well is appreciated. Maybe my experience myself is limited. I did a literature review with this. We don't see it every day. Not sure. Interventionists through this era obviously went through all these changes with the using of these agents. So I don't know if there is any personal experience, Dr. Berg, sorry to call you, but basically, what's your input or what's in terms of using these agents? Do you use them? Do you see people using them? What's your thoughts?
Well, it's been very interesting over the years because we used a lot of glycoprotein inhibition in the past. One of the big hopes for glycoprotein inhibition is that it would be useful as an adjunct to thrombolytic therapy and in the treatment of STEMI. And the GUSTO-4 trial showed definitively that it was not. The problem is that thrombolytics, of course, activate platelets. And it was thought that the addition of a glycoprotein inhibitor, in addition to thrombolytics, would be kind of the final treatment algorithm that would show that thrombolytic therapy was the treatment of choice for myocardial infarction. And the GUSTO-4 trial showed that, of course, it was not. There was excess, and there was a whole lot of bleeding. I helped participate in some of the very early studies of glycoprotein inhibition, and we knew, particularly the Merck product, the tirofiban product. It was at that point it was called MK383. And participated in, I can't even remember which of the trials it was, but it was the tirofiban versus placebo. And you knew they got the tirofiban because the clot went away and they got a hematoma. And so the bleeding risk became quite an issue. And it's actually because of that we really started looking at bleeding as a complication of what we do in the cath lab, that bleeding is really a bad thing. It's associated with increased mortality and increased morbidity, not just, even large hematomas can be. So we used glycoprotein inhibitors for a long time. We used them a lot. They are very effective. I will say that you summarized it pretty nicely. Right now, I think they're limited, and most of us just use integralin because that's just sort of the way it worked out. Obviously, abciximab Riopro is no longer available, and it was also very expensive compared to the other agents. But we use glycoprotein inhibitors if there's a huge amount of clot. I will use it in acute stent thrombosis, which we see fortunately very, very rarely. And that's pretty much what it's limited to. And a lot of times we'll just give a couple of boluses. Oftentimes they will be intercoronary boluses just for ease of administration, not anything else. Oftentimes without a drip. And then I think your summary on cangrelor was appropriate. The times that I'll use cangrelor now are when I'm worried about the uptake of the oral P2Y12 inhibitor, particularly in patients with cardiogenic shock, cardiac arrest patients, who not only it's difficult to get the medication into them, but their GI system is sort of slowed down and the actual absorption is slowed. So I'll often use cangrelor. The nice thing about cangrelor then, is we tend to use a lot of Brilinta here relative to Prasugrel because of the black box warnings, I think, on Prasugrel. For older people and people with prior history of strokes. So we'll use cangrelor I'll use cangrelor pretty much exclusively in that situation. Otherwise, I don't see a great deal of need for it.
Excellent. Thank you so much. Yeah, thank you.